Hello, my name is John Kelly. I'm a personal injury attorney in Phoenix, Arizona, and I'm glad you found your way here because if you're searching this topic, you're probably carrying something heavy. Maybe you're worried about your mom in assisted living. Maybe your dad is in a nursing home after a hospital stay and the phone calls feel just off. Maybe your brother lives in a group home because he needs daily support and you've noticed changes you can't explain. Or maybe someone you love is in memory care, where they can't always tell you what happened, even when their body is trying to. When a person becomes a vulnerable adult, the world changes, and ordinary risks of life, they just get sharper, and a duty on caregivers gets bigger. This series is meant to give you some clarity in plain language for your families and a practical strategy for attorneys so you can understand what may be happening, what should be happening, and what you can do next. A quick but important note, this is general education information. It is not legal advice for your specific case. Every state's laws do differ and details do matter. And one more note that matters even more. If you believe a vulnerable adult is in immediate danger, call 911. If you suspect sexual assault, serious physical harm, or a crime that might be in progress, involve the law enforcement right away. Safety first. You can deal with the paperwork later on. This is an educational series that should guide you if you suspect that this is going on for you or someone that you love. I hope that it's helpful for you. And we'll start with chapter 1, which is how vulnerable adults get hurt and the common pathways of abuse and neglect. In this first chapter, we're going to talk about how vulnerable adults are most commonly harmed in assisted living, nursing homes, and skilled nursing facilities. It would include group homes and memory care facilities. Understanding the common pathways sets the stage for everything else, from medical insight to legal strategy. Because these cases rarely start with a headline moment, more often they start with a pattern, a quiet pattern, the kind that can be explained away until it can't be explained. Let's start with the big idea. In facility abuse and neglect cases, the injury is often not one bad day, it's a chain of missed care, missed supervision, missed escalation, and missed dignity. And when the chain gets long enough, something breaks. Skin, bones, lungs, kidneys, or life itself. So what are the most common pathways? One pathway is basic neglect, dressed up as natural decline. A resident loses weight, and the chart says poor appetite. They stop walking, and it's called deconditioning. They become confused, and it's blamed on dementia. They develop a wound, and someone shrugs and says, fragile skin. Sometimes decline is real. Aging is real. Disease is real. But when decline happens fast or in clusters, or when the same excuses are every time, you should look harder because neglect also has a pattern. Another pathway is falls, especially preventable falls. Falls happen, people are human, gravity does not negotiate. But in care settings, a fall is often a symptom of a plan that wasn't followed. Think about the most common scenario. A resident needs help toileting. The call light goes unanswered. They try to go alone, and they fall. Or a resident needs two-person assistance for transfers. Staffing is thin, someone tries it solo, and they fall. Or a resident is sedated, unsteady, and nobody increases supervision. They fall. A fall isn't automatically negligence, but the risk was known, and precautions were written down, and precautions were not done. That's where accountability starts to live. Another pathway is medication management or mismanagement. This includes the obvious: wrong medications given, wrong dose, missed doses. But the more common and more dangerous version is subtler. oversedation, and chemical restraint. A vulnerable adult becomes too much, too restless, too anxious, too confused, or too loud. Instead of adding staffing, the system just adds medication. The resident gets quieter, but quieter is not healthier. Oversedation can lead to falls, aspiration, constipation, delirium, and a kind of slow disappearance from life. Families often describe it as they were themselves and then suddenly they weren't. Another pathway is infection, especially the UTI to sepsis cascade. It often starts with dehydration, poor hygiene, missed symptoms, and delayed escalation. A urinary tract infection can cause delirium. Delirium can cause falls, or the infection can spread and become sepsis. And sepsis can move like a wildfire through a frail body. In a well-run facility, changes get noticed early and acted on. In a poorly run one, changes get rationalized until the hospital is the only option left. Another pathway is aspiration and choking, especially in nursing homes and memory care facilities. Swallowing issues are common in frail adults. Stroke survivors and people with dementia often suffer from this too. If a person needs supervision at meals, diet modification, or swallow precautions, those aren't suggestions. They are safety equipment. When those precautions get ignored, aspiration pneumonia becomes the predictable result. Another pathway is pressure injuries, what most people call bedsores. Pressure injuries don't happen because a person is old. They happen because pressure is not relieved, skin is not checked, moisture is not managed, and nutrition is not supported, and wounds are not treated early. Yes, some wounds can develop even with good care, but deep pressure injuries often tell a story of time spent in one position, time spent wet, time spent unseen. Another pathway is violence, and this can be staff on resident abuse, physical, sexual, emotional. It can also be resident on resident violence, especially in memory care, where aggression can be a symptom of cognitive disease. Facilities sometimes pretend these categories don't exist, but families see it in bruising, fear, withdrawal, and sudden behavioral changes. And then there's elopement, wandering out. When someone with cognitive impairment leaves supervision, the danger multiplies quickly. Traffic, heat, cold, water, and falls are the simple terror of being lost. Elopement cases are among the most devastating because the harm can happen fast and because it usually means that basic systems failed. The doors, alarms, staff, attention, care planning, and response. Now let's bring this to human scale. Imagine an 82-year-old woman. Let's call her Miss Ramirez. She moves into assisted living because she needs help with meals and medication reminders. She's proud, she's independent. She tells her daughter, "I'm fine, don't worry." At first she feels fine, and then her daughter notices her mom's clothes are looser. She's tired, she seems a little snowed. When the daughter asks, the staff says, "She's just adjusting." 2 weeks later, Miss Ramirez falls. The facility says, "Oh, she insisted on walking without our help." At the hospital, the daughter learns her mom is dehydrated. Her blood pressure is low. She has a UTI, and she's on new sedating medication that wasn't discussed with the family. Was this just aging, or was it a chain of preventable failures? That's the question in these cases. If you're attorneys listening, this is where you start building the theme. Foreseeable risk, accepted resident, knowing needs, missed care, and predictable harm. If you're a family member listening, this is where you start trusting your instincts. If the story doesn't fit, don't force it to. This chapter is understanding the care settings. So we're going to talk about assisted living versus nursing home versus group home versus memory care. If you're watching this, it's likely that you're trying to make sense of a system that feels confusing on purpose. In this chapter, we'll talk about what these care facilities actually are, how they differ, and why the setting matters medically and legally. In the last chapter, we talked about the common pathways of harm: neglect, falls, medication errors, infections, pressure injuries, violence, and wandering. Now let's pause and understand the playing field. Because when you know what kind of facility you're dealing with, you can ask better questions and recognize red flags faster. A vulnerable adult is not just someone who is older. It can be an elder. It can be a person with disabilities. It can be someone with a brain injury, a developmental disorder, serious mental illness, or memory loss. The common thread is not age, it's dependence. So a vulnerable adult depends on others for safety, care, supervision, or decision-making. And when dependence increases, the standard of care rises within it. Now, the four major settings families run into are assisted living, nursing homes, skilled nursing facilities, group homes, and memory care. These labels sound clean. Real life is typically not. Let's talk through each one. First, assisted living. Assisted living is often marketed as help with daily living rather than medical care. Families hear things like meals, housekeeping, medication reminders, bathing assistance, social activities. It often looks like apartments with dining hall and calendar full of events. It can be a good setting for the right resident. But here's the uncomfortable truth. Assisted living has increasingly become a place where people with high medical needs live because families need somewhere to put them. Hospitals need somewhere to discharge them, and facilities know how to sell hope. The assisted living staff may include caregivers and med techs. Some have nurses on staff, some have limited nursing presence. The depth of the medical oversight can vary wildly. So in assisted living cases, the core legal question is often, what did the facility agree to do? What did the resident actually need? And did the facility accept the resident anyway? Because duty follows acceptance. If you accept a resident with a known fall risk, known incontinence, known swallowing risk, known skin breakdown risk, or cognitive impairment, you don't get to act surprised when the harm occurs. Nursing homes and skilled nursing facilities, sometimes called SNFs, this is higher acuity. More residents are medically complex, bedbound, or recovering from hospitalizations. There's supposed to be more clinical monitoring and more nursing responsibilities. And you'll see things like care plans, treatment records, wound documentation, assessments, and physician involvement. In nursing home and SNF cases, there are often more records, more measurable obligations, and therefore more ways to prove what should have happened and what didn't. But here's the paradox. More regulations doesn't automatically mean better care. Sometimes it means better paperwork. And sometimes paperwork becomes a camouflage. Now I'll talk about group homes. Group homes vary more than almost any other setting. Some are loving and stable, well run. Some are understaffed and undertrained and designed to run on the cheapest labor possible. So group homes often serve adults with developmental disabilities, traumatic brain injuries, serious mental illnesses, mobility impairments, seizure disorders, or complex behavioral needs. Group homes can be small, 4 residents, 6 residents, 8 residents, and they can feel more like home-like, which families like, but small can also mean isolated, and isolation is where abuse hides. In a group home, supervision is often the linchpin. If a resident needs constant line of sight supervision and the home has 1 staff for 6 residents, the math just doesn't work. If a resident has a known choking risk and meals are rushed, harm is predictable. If a resident has behavioral outbursts and the staff isn't trained, restraint and injury become the default response. Now we'll talk about memory care. Memory care is not just assisted living with locked doors, it's its own standard of care. Memory care residents are often living with dementia or other cognitive disease. That means impaired judgment, wandering risk, or increased fall risk, and difficulty communicating pain, and sometimes aggression or fear-based reactions. Memory care should mean trained staff, environmental safeguards, consistent routines, protection from elopement, protection from resident-on-resident harm, and a care plan that anticipates predictable dementia behaviors. When a memory care fails, it often fails in two ways. The environment isn't safe, and the human response isn't skilled. Now let's talk about the most important concept across all settings. Marketing doesn't define duty. The resident needs to define duty. Facilities often try to hide behind labels. We're not a nursing home. We don't provide medical care. We're just assisted living, or some of the things you might hear. But if they accept someone who cannot safely toilet alone, cannot safely ambulate alone, cannot manage medication, cannot swallow safely, cannot protect their own skin, or cannot stay inside without wandering, then they have accepted a duty to manage those risks. This matters for families because you can trust your instincts when you see mismatch. If a facility looks like a hotel, but your loved one needs hospital-level attention, that mismatch is a danger. It matters for your family because it becomes your theme. They took the money, they took the resident, they took the duty, they tried to disclaim it after harm occurred. Now let's briefly talk about how care is supposed to be organized. Care plans, service plans, and the reality gap. Most care plans are supposed to have some version of a plan. In assisted living, you'll often see a service plan. What assistance will be provided? In a skilled nursing, you'll often see a formal care plan and assessments. In group homes, you may see an individualized plan or behavioral plan. Sometimes these are tied to disability services. The plan is supposed to answer what risks exist, what interventions are required, who is responsible, and how often must care occur. It's also assessing how will changes be identified. But here's what happens in bad facilities. Plans are written to satisfy admissions, regulators, and families. And then the floor runs on crisis. Call lights go unanswered. Turning schedules skipped. Waits are missed. Wound checks delayed. Toileting plans ignored. Aggressive residents not separated. Medications not reconciled. Hospital discharge instructions filed away like a junk mail. The plan becomes a piece of paper that everyone points to, but nobody lives up to it. If you're a family working with an attorney, this is where you build your evidence. You show the plan, you show the staffing, you show the charting, show the gap, because the gap is negligence. Now a word about corporate structure. In modern elder abuse and vulnerable adult cases, the facility is often not one entity. There may be an owner, a managing company, a license holder, a real estate entity, and outside staffing agencies. It can look like a corporate shell game. So why does this matter? Because the responsibility often sits at the level where the staffing is decided. And staffing is often a business decision, not a clinical one, which brings us to the theme you'll hear me repeat. Understaffing is not an accident, it's often a business model. Now, before we move on, I want to give you a quick checklist, family-facing, plain-spoken, of questions that cut through the fog. If you're touring or you're already worried, ask, who is the nurse on duty and when? Is the nurse on site overnight? What is your staffing ratio on days, evenings, and nights? How do you handle toileting assistance? How quickly are your call lights answered? How do you prevent falls or high-risk residents? How do you prevent and treat pressure injuries? Who does the skin checks? How do you handle residents who wander? What alarms and checks exist? If my loved one reports pain or change in condition, who evaluates and how fast? How do you prevent resident-on-resident violence? If there's any incident, how and when will the family be notified? Do you have cameras? If so, where? How long is the footage kept? A good facility answers directly. A bad facility answers with smiles and vagueness. Now that we understand the settings, we can talk about the injuries and red flags, the medical realities that show up when a care is missing. In the next chapter, we'll talk about the specific injuries and harm patterns common in these cases. That is, pressure sores, their stages, malnutrition and dehydration, fractures, aspiration pneumonia, UTI to sepsis pathways, medication errors, assault, and the ways wrongful death often unfolds in facility neglect cases. We'll also talk about what these injuries mean, not just medically, but legally, because in many cases, the body becomes the witness when the vulnerable adult cannot speak. In this chapter, we'll talk about the most common injuries and red flags in vulnerable adult abuse and neglect cases, and why these injuries often tell a story even when the person cannot. In the last chapter, we define the types of care settings and why the label on the door doesn't control the duty. Now we're going to look at the physical evidence because in these cases, the body is often the witness. That's one of the cruelest parts of vulnerable adult cases. The person who knows what happened may not be able to describe it. They may have dementia, they may be nonverbal, they may be afraid. They may have been told directly or indirectly that speaking up will make things worse for them. So you have to learn how to listen to what the body is saying. So let's now walk through the major injury categories. Pressure injuries or bed sores. The signature of missed care. Pressure injuries are one of the clearest red flags in facility neglect cases because they are often preventable with very basic and consistent care. A pressure injury is tissue damage caused by unrelieved pressure and impaired blood flow. When the pressure stays too long, especially over bony areas like the sacrum, heels, hips, and ankles, skin and underlying tissues start to die. Families often first notice redness that doesn't go away, a blister, a dark purple area, or a wound that just looks deep and serious. Clinically, pressure injuries are staged. You'll hear words like stage 1, 2, 3, 4. Here's a plain language breakdown. Stage 1 is usually intact skin with persistent redness. Stage 2 is partial thickness, often like a blister or shallow open wound. Stage 3 is deeper, full thickness tissue loss. This can look like a crater. Stage 4 is the worst, deep tissue loss, sometimes exposing muscle, tendon, or bone. You may also hear unstageable, which is covered by dead tissues so the depth can't be seen, or deep tissue injury, which is dark discolorization signaling deeper damage beneath the surface. Now, an important concept to go over. A deep pressure injury is rarely a surprise event. It's usually the end of a process. So there's prevention basics, and they include regular repositioning for bedbound residents, offloading pressure, especially the heels, keeping the skin clean and dry, managing the moisture from incontinence, nutrition and hydration support, and early intervention when redness appears. So when you see an advanced pressure injury, it's fair to ask, was the turning schedule followed? Were the skin checks documented? Were incontinence and moisture managed? Was the resident assessed as high risk? Was the care plan updated when risk increased? Was wound care started promptly and appropriately? If you're a family looking at this is where the record tells the truth. The Braden risk scores, if documented, turning the positioning logs if they exist, wound measurement trends, treatment orders, TAR entries, and timing of when the wound was first charted compared to when the family first started it is what attorneys like myself will be looking at. And if there's a sudden jump, skin intact 1 week, stage 4 the next, be alert. Sometimes that jump is negligence. Sometimes it's documentation failure. Sometimes it's chart manipulation. Your job is to find out which, and your attorney should be able to help you with that by ordering the records and evaluating it. Malnutrition and dehydration, the slow emergency. Weight loss is often earliest sign that care is slipping. Malnutrition isn't just they didn't feel like eating. In facilities, malnutrition often results from the meals are delivered but not assisted. Food is too difficult to chew or swallow safely. The lack of supervision for someone who forgets to eat, depression or medication effects, or simple neglect. Sometimes trays removed untouched day after day. So dehydration is the twin of malnutrition. A vulnerable adult may not feel thirst normally. They may not be able to access water. They may not need reminders or help to drink water. They may avoid drinking because they're afraid staff won't help them to the bathroom. Dehydration can trigger constipation and then UTIs, delirium, often falls and kidney injury, and a general crash in resilience. Family-facing red flags include if they have loose clothing, sunken appearance, a dry mouth, fatigue, they have new confusion, dark urine, and repeated little infections that keep coming back. So for attorneys like myself, the evidence often includes weights and how often they were taken, intake records, dietitian notes, swallow evaluations, care plans for feeding assistance, and very importantly, whether the changes were escalated to a physician and communicated to the family. Now we'll go over falls and fractures. Falls are common, but serious falls are often a pivot point where a vulnerable adult's life changes permanently. A hip fracture can be catastrophic. Even when surgery goes well, the aftermath often includes immobility, pain, delirium, infection risk, blood clots, pneumonia, and sometimes permanent loss of independence. A fall can also cause a head injury, a subdural bleeding, concussion, cervical spine injury, in frail adults, even a simple fall can become a long hospitalization. In a prolonged rehab stay and rapid decline can often follow. The legal and clinical question is not only did they fall, it's was the fall foreseeable and were the reasonable precautions in place to prevent it. There are common facility-related contributors, and they include unanswered call lights, missed toileting schedules, inadequate transfer assistance, poor supervision after medication changes, clutter or poor lighting, unsafe footwear, and failure to use appropriate alarms and mobility aids. We'll also talk about medication errors and chemical restraint. Medication errors can be obvious. They give the wrong drug, the wrong dose, but chemical restraint is often quieter. Chemical restraint is when medication is used primarily to control behavior rather than to treat a legitimate medical condition with appropriate monitoring and consent. Families will often describe, she's sleeping all the time. He's not interested in anything anymore. He seems foggy, like he's not here. She started falling right after the new medication. Medications that commonly raise concerns in these settings include sedating, antipsychotics, benzodiazepines, opioids, and combinations that amplify sedation. This is where the PRN usage matters. This is where the timing and med changes compared to the falls and decline matters. So as an attorney evaluating these, the question is, when was the medication started? Who ordered it? Was there a behavioral assessment? Was the consent obtained if required? Was there monitoring for side effects? Was the medication used as substitute for staffing? Now I want to talk about aspiration pneumonia. When swallowing risk is ignored, aspiration pneumonia is a common and often preventable cause of death in vulnerable adults. Aspiration happens when food, liquid, or saliva enters the airway and lungs. A person with dysphagia may cough while eating, pocket food, choke, or have wet vocal quality. Facilities are supposed to respond to swallowing risk with swallow evaluations, diet texture modifications, thickened liquids when necessary, upright positioning, slow feeding, supervision, and good oral care. Oral care matters because bacteria in the mouth can become the bacteria in the lungs. Neglecting oral hygiene can increase aspiration pneumonia risk. Families often will hear, they just got pneumonia, but sometimes just pneumonia is the end of a long chain: ignored choking episodes, poor supervision at meals, missed swallowing precautions. Now I want to talk about UTI, infection, and sepsis. The cascade. Sepsis is not a fancy term. It's the body's emergency alarm system going off and sometimes shutting down. In vulnerable adults, infections often begin quietly. A UTI, a wound infection, an untreated respiratory infection. Early signs of this can be very subtle. There could be new confusion, lethargy, reduced appetite, or fever, or low temperature, rapid breathing, rapid heart rate, weakness, or not acting like themselves. In a well-staffed setting, those changes prompt evaluation and escalation. In a poorly run setting, those changes get charted and watched until the resident crashes. If you're a family member, this is where you trust urgency. Sudden change in mental status is not something to monitor for a day or two. It's something to evaluate now, especially if the person is frail. As an attorney, looking at these, we look for vital sign trends, nursing notes about confusion, delays in contacting a provider, gaps between the symptoms noted, and hospital transfers. I'll now talk about physical and sexual abuse. The injuries and fear abuse is real in care settings and is often underreported. Physical abuse can show up as bruises in unusual locations, inner arms, wrists, or torso, injuries with vague explanations, pattern of bruising or injury inconsistent with the resident's abilities. It can also show up as fear, flinching when approached, withdrawal, sudden agitation during care, or a resident pleading not to be left alone with a particular staff member. Sexual abuse can be even harder to detect, especially if the resident has cognitive impairment. Any concern about sexual assault should be treated with seriousness and urgency. Do not allow a facility to handle it internally. Emotional abuse is harder to photograph, but it's real. Humiliation, threats, isolation. Sometimes the resident can describe it, but sometimes they can't. Sometimes they can't, and their behavior just changes. Resident-on-resident abuse and violence is a known risk in memory care. Memory care facilities know this is a problem and exists. Aggression can be part of dementia, and some residents wander into other residents' rooms. Some become territorial or fearful, some strike out. Facilities have a duty to assess and manage this risk. They have to do care planning, supervision, room placement, behavioral interventions, staff training, and separating residents when necessary. When the facility tells you residents just get into altercations, well, that might be true, but true is not the same as acceptable. If a resident is repeatedly injured, there's often a failure of supervision and planning. Elopement, the consequence of one open door. Elopement means leaving supervision, walking out. This is especially common with dementia and developmental disability. Risk factors include prior wandering, restlessness, exit-seeking behavior, confusion, and poor impulse control. Preventing elopement is not rocket science, but it requires systems. It has to have doors alarmed, secured, perimeters set up, staffing patterns that allow observation, and a care plan that treats wandering as a medical risk. When someone elopes, the questions are immediate. How did they get out? How long were they gone? What was the monitoring that was existing? Was the risk known? Was the family notified promptly? Was the law enforcement called promptly? Wrongful death pathways. How neglect ends in these cases. Death is often not a lightning strike, it's a predictable endpoint. Common wrongful death pathways include a fall that leads to a hip fracture, surgery, and then pneumonia or sepsis. A pressure injury becomes infected and progresses to sepsis. Aspiration pneumonia follows ignored swallowing precautions. Dehydration and infection spiral into organ failure. Medication or oversedation leads to a fall or aspiration. Elopement leads to exposure, trauma, or fatal injury. Assault leads to head injury or internal injury that is not timely treated. Understanding these pathways matters because facilities' insurers often try to erase the chain. They'll point the final event, pneumonia, sepsis, cardiac arrest, as if it came from nowhere. The final event usually has roots. Your job is to trace them back. Now let's end this chapter with another short story. Imagine a man in a memory care. Let's call him Mr. Johnson. He's a gentle person, but he wanders. His care plan calls for redirection and supervision, especially at night. One weekend, the facility is short-staffed, and Mr. Johnson wanders into another resident's room. That resident is confused and frightened. There's an altercation, and Mr. Johnson is struck and falls, hits his head. The facility tells the family it was an accident between residents. But the real question is, why was a known wandering resident unobserved long enough to enter another room? Why wasn't the environment controlled for predictable dementia behavior? That's not just unfortunate, that may be negligence. Now that we've discussed the injuries and red flags, we need to talk about what you can do both for safety now and for the accountability later. In this chapter, we'll talk about immediate safety steps, reporting options like Adult Protective Services and Ombudsman. And if the case becomes legal, how we prove neglect or abuse when the evidence is scattered and the vulnerable adult may not be able to testify clearly. We've talked about how harm happens and what it looks like medically. Now we can move to action. And I'm going to be blunt here. In many facility cases, time is your enemy. Wounds will evolve, bruises fade, videos get overwritten, charts get cleaned up, witnesses leave. And the resident's condition may worsen, sometimes quickly. So the goal is twofold. One, protect the person now. And two, create an outside record that can't be rewritten later. Step 1, safety before strategy. If your loved one is in danger, don't negotiate with the facility. Don't wait for Monday. Don't accept. We'll look into it. Get them medically evaluated. That may mean calling 911. That may mean taking them to the ER. That may mean insisting on a provider assessment now. And here's why. Hospitals create independent records. EMS creates records. Imaging creates records. Lab work creates records. And those records are often the most trustworthy snapshot of what was happening at the time. If you suspect abuse, especially sexual abuse, tell the medical provider that you suspect abuse. Use that language. Don't soften it or anything like that. Medical terms can activate protocols and they can document findings that matter to us later. Step 2, reporting. You want to create an outside track of accountability. So families often ask, who do I report this to? There are usually several channels that they can report to, and they serve different purposes. Adult Protective Services, or APS. APS exists to investigate abuse, neglect, exploitation of vulnerable adults. And in many states, filing an APS report is one of the most important early steps because it creates a government record and it can trigger an investigation. Sometimes people refer to adult abuse reports with shorthand terms depending on the state or intake system, what you call ABSA style reporting concepts. The key idea is the same. You are creating an official report that a vulnerable adult may be unsafe. APS can interview, obtain records, coordinate with law enforcement when needed. The process is not perfect, but it matters and it often gives you leverage. Now, there's the long-term care Ombudsman. The Ombudsman program exists to advocate for residents in long-term care facilities. They can help mediate issues, push for improvements, guide families through complaints. The Ombudsman is not a law enforcement. They are not your lawyer, but they can be an important ally, especially in getting facilities' attention and documenting the problems that exist. There's also licensing and survey agencies. Most facilities are licensed, and some are certified under the state and federal rules. Filing a complaint with the licensing agency can trigger surveys, inspections, and citations. Again, the system is not perfect, but a survey finding can be powerful evidence because it's an outside authority saying this facility failed to meet its standards. If there's a crime, an assault, a sexual abuse, theft, serious physical harm, call the police. Do not let the facility talk you out of it. Facilities sometimes refer to keep everything internal. That is exactly why external reporting exists. Now, an important reality check. Reporting can be emotional. It can feel confrontational. It can feel like you're accusing people. But the purpose of reporting is not to create drama. It's to protect the person who cannot always protect themselves. Step 3, document like you're building a timeline, because you are. If you suspect harm, start documenting immediately. And there's family-facing documentation tools. You can photograph injuries and wounds, photograph the clothing, the bedding concerns, get the environment in the photographs. Keep a simple log of dates, times, of what you saw and who you spoke with. Try to log what they said and save your texts, emails, and voicemails. Request care conference notes and written plans, and write down the names of the staff you interact with. This is not being paranoid, it's about being prepared. Attorney-facing documentation goes deeper, and it should start early. Attorneys like myself will send an early preservation letter that will target all medical records from the facility, including EHR metadata and audit trails. It can target care plans and service plans, MARs and TARs, wound logs, wound photos, and treatment orders, weights and nutrition records, CNA flow charts, ADL assistant documentation, toileting logs, incident reports, and internal investigation materials. It can also include staffing schedules, assignments, agency staffing records, call-outs, training records and competency checklists, prior complaints, surveys and correction of action plans, where discoverable, video footage, hallway cams, entrance cameras, common areas that have cameras, and retention policy. We can trigger communications that they have within the facility, including emails, text, internal messaging about the residents. Why this matters? In modern facilities, the chart is often electronic, and electronic records can be edited. Audit trails, who charted what, when, and what was changed can become quite key in unlocking the full story. So step 4 is choosing the legal theory, and your attorney can help you determine negligence versus medical malpractice versus statutory abuse. Facility cases can involve multiple legal theories. The best cases often do. Negligence is the first to cover. This is the baseline. Failure to use reasonable care. Negligent supervision, negligent care, negligent staffing, negligent falls prevention are all types of negligence that we can plead. Now, some facilities' harm is truly medical. Wound care decisions, medication management decisions, failure to escalate to providers, failure to follow discharge instructions, failure to monitor a known condition. Depending on the state, medical malpractice has different procedural requirements. There's experts, affidavits, shorter deadlines, damage limitations, so on. So you need to analyze early, and we are in mid-mal territory, negligence territory, or both is a question that you can ask your lawyer. Corporate negligence. This is where the story gets bigger than the one caregiver. Corporate negligence is about system failure. That is understaffing, the lack of training, poor hiring and retention, poor policies and culture that tolerates shortcuts. If the facility is chronically understaffed, that is not a random event. It is a decision. And if that decision foreseeably causes harm, corporate negligence becomes the spine of the case. Physical abuse and sexual abuse can implicate battery, assault, and intentional misconduct. These claims can change the case value and the emotional narrative, and sometimes open doors to punitive damages. Many states have statutes designed to protect elders and vulnerable adults, sometimes with enhanced remedies when neglect is reckless or when the conduct is particularly egregious. There isn't one set of statute that fits every state. Every state is a little bit different, but conceptually, these laws recognize something important. Abusing or neglecting a vulnerable adult is not just ordinary negligence, it is a betrayal of a special trust. When the neglect leads to death, the legal framework often includes a wrongful death claim. The family's losses is what that is, and the survival claims, the decedent's losses before death. And this is all depending on jurisdiction, how it's pled. There's a hard truth. In many facility cases, death is the defense's strategy. Not explicitly, of course, but practically. Because if the resident dies, the defense often assumes the case value drops. They were old, they were sick, they were going to die anyway. My job as an attorney is to burn that argument down with dignity and detail. Yes, they were old. Yes, they had conditions, and yes, they deserved safety, comfort, and basic care. They still had a life, and they did not deserve a preventable, painful death. Step 5, proving causation when the resident has comorbidities. This is where the cases get technical. Vulnerable adults often have comorbidities. They'll have dementia, diabetes, kidney disease, heart disease, maybe mobility impairment, prior strokes. Defense will try to blame the injury on the baseline. They will say the decline was inevitable. Sometimes decline is inevitable. Neglect is not, though. Causation in these cases is often about acceleration and aggravation. Did the facility's failures accelerate decline? Did they turn manageable condition into a crisis? Did they transform the risk into harm? If a resident was walking with assistance and a preventable fall broke their hip, that is not inevitable. If a resident has dementia but was stable until dehydration and infection caused delirium and a fall, that chain matters. If a resident had fragile skin but the facility failed to reposition and a stage 4 wound developed, that wound has causation roots. This is where medical records, timeline, and expert testimony converge. Step 6, the experts. Translating care failures into the standards. In facility cases, the right experts often include nursing experts to speak to the standard of care for supervision, the skin care, the infection prevention, documentation, and staffing. Wound care experts for pressure injuries. Geriatricians for internal medicine physicians for causing decline patterns and preventability. Pharmacology experts for medication errors and chemical restraint themes. Psychiatrists or neuropsych experts in cases involving behavior, delirium, or cognitive baseline. Life care planners and economists for future needs and valuation. In some cases, facility administration experts who understand the staffing, they understand the budgeting, and the operational decisions. Your experts should not just say negligence, they should explain the practical why. This is what a competent facility would do. This is what this facility did instead. And this is how that difference caused the harm. And if you can, pair that with the simplest possible human truth. This didn't have to happen. A note on facility cooperation. Don't expect it. Families often expect that if they raise concerns, the facility respond transparently. Sometimes they do, but often, once a facility senses exposure, the tone changes. You may see defensiveness, minimization, blaming the resident, or sudden claims that everything was documented. As an attorney, such as myself, I anticipate these things. As family, you shouldn't take it personally. It's not about you, it's about liability. Now let's tie this together with a quick story. Imagine a resident, Miss Lee, who develops a pressure injury. The family notices it on Saturday. They're told, "We just noticed it too." They take photos. They take Miss Lee to urgent care, and the provider documents advanced pressure injury with signs of infection. An APS report is filed. A complaint is filed with the licensing agency. When an attorney like myself later gets records and facility charts show skin and act through Friday, but the wound is too advanced for that timeline to be credible, now the case has something powerful: outside documentation, the photos, the independent medical assessment, and a question about the honesty of the charting. That's how you build proof. Now that we talked about safety steps, reporting, and the foundation of providing these cases, we're ready for the next chapter, because once you establish what happened and why it mattered, you have to answer the hardest practical question: what is it worth? In this chapter, we'll talk about how damages work in vulnerable adult abuse and neglect cases, economic losses, non-economic harm, and the themes that tend to drive high-value outcomes. So this is going to be the dollars and cents part of the journey. And although it's an emotional journey all around, at some point we have to talk about the dollars and cents of the situation. And I want to say something right up front, because families often feel guilty when thinking about money. Talking about damages is not greedy. It's not making a big deal. It's not disrespecting the person you love. It's the reality. Because these cases are expensive, the harm is expensive, and the only tool civil law has to respond is compensation. Now, money can't unbreak a hip. It can't erase humiliation. It can't restore a mind lost to delirium and decline. But it can pay for care. It can pay for safety, therapy, and supervision. It can stop the financial bleeding while a family tries to heal. So let's talk about damages in a clean, structured way. Economic damages first. And these are the costs that you can add up. In vulnerable adult cases, economic damages often include the medical bills, the hospital costs, ambulance and emergency care, wound care visits, surgeries for fractures, IV antibiotics for infections, ICU stays for sepsis, rehabilitation and therapy. Increased level of care is going to increase the costs, and this is a big one. Sometimes the resident was in assisted living and now must be moved to a skilled nursing facility. Sometimes they were in skilled nursing and now need memory care or hospice. Sometimes they need one-on-one supervision, private sitters, or someone because they are now too unsafe to be alone. Sometimes the family takes them home and the family becomes the staff. Those changes cost money and they're out-of-pocket expenses. So some of the other out-of-pocket expenses and economic damages include medical supplies. So we're talking about special mattresses or support surfaces, mobility devices, transportation, home modifications in the residential home. In wrongful death cases, economic damages may include funeral and burial costs, final medical expenses, and sometimes the value of services the person provided, depending on the law of the state. Now, as an attorney, I know the economic damages are only half of the story, sometimes less, because the heart of these cases is really the non-economic harm. So what's important to understand is the non-economic damages, and this is the harm that doesn't come with receipts. Non-economic damages can include the pain, the pressure injuries, the hurt, the fractures, the aspiration that hurts, the sepsis hurts, and the end-of-life context. Suffering is not theoretical, it is lived. Emotional suffering and fear. Imagine being confused, in pain, unable to have final words, and dependent on strangers. Imagine being left in the wet bed. Imagine being rushed and handled roughly, mocked, or ignored. That fear counts as damages. We also have non-economic damages that include loss of enjoyment of life. Even in advanced age, people still have joys, often great joys, family visits, their favorite music, sunlight on a patio, dignity during bathing, feeling safe in bed at night. The neglect can steal those small joys first, and those are damages. Loss of dignity. This is one of the most important harms in vulnerable adult cases, and one of the hardest to explain to a jury until you explain it plainly. Dignity is not abstract. Dignity is being clean. Dignity is being listened to. Dignity is not being left on your own to waste. Dignity is not being treated like an inconvenience. When a facility takes a human being and treats them like a task list, that is harm. Another damage is loss of consortium, and this is family impact. Spouses and families often suffer their own losses, watching a loved one in decline, carrying the caregiver burden, living with guilt and anger, and losing the relationship as it was before. Now, in many states, there are rules about who can claim what and how, but the concept is constant. Harm radiates outward. A vulnerable adult case is rarely just the resident. It becomes a family injury. So what are some of the high case value themes? What drives the serious exposure? We can talk about what tends to make these cases a high value, because if you're like me, you need to spot these themes early, and if you're a family member, you deserve to know why some cases create more leverage than others. So the first theme we'll talk about, deep pressure injuries, especially when infected. A stage 3 or stage 4 pressure injury, especially if there is an infection, sepsis, and hospitalization, and these often create signals that we see of prolonged neglect and system failure. It's not just the wound, it's what the wound represents. And that's what drives the damages of missed repositioning, missed skin checks, missed hygiene, missed nutrition, missed escalation. The second theme that we'll talk about is malnutrition and dehydration with documented weight loss. When a resident loses significant weight and develops repeated infections, becomes lethargic, and then crashes, the defense can try to call it a decline. But a documented weight loss trend is a measurable story. It is neglect that can be graphed. Another theme that we can talk about is medication over-sedation and falls. When a facility uses medication as a substitute for staffing, and the resident then falls or aspirates, the jury understands the moral math. They choose convenience over safety. The fourth theme, resident-on-resident violence with known prior incidents. If there were prior incidents and the facility did not change supervision, room placement, or staffing, then the harm is not unexpected. It's foreseeable. We'll talk about the fifth theme, elopement, especially with serious injury or death, are often a high case value because the public intuitively understands a locked memory care unit is supposed to prevent wandering out. If a person walks out, systems have failed. Another theme 6, is sexual assault. Sexual assault in a care setting is one of the most devastating violations imaginable. These cases often involve profound non-economic damages, and they can open doors to punitive exposure and system claims about hiring screening, the supervision that they had, and reporting failures. Theme 7 for damages is wrongful death with clear chain. When the case narrative is clean, failure to turn leads to pressure injury, leads to infection, leads to sepsis and death. It can become a powerful story of preventable suffering. Now let's talk about a hard defense argument you'll hear. They were old, they were sick, they didn't have much time left. But here's the truth. The value of human life is not measured in remaining years alone. A vulnerable adult still has a right to comfort, safety, and dignity. If a facility causes a preventable, painful injury, the law does not excuse it because the person was 88 instead of 28. And juries will understand that deeply. They may not talk about the statutes. They talk about decency, about what we owe each other when someone can't fend for themselves. So I'll go over the damage modeling that we do and how we present it to juries. In a serious case, we often use a life care plan or a similar framework, even when the resident is older, because the question is, what did this harm change? Did it increase the level of care? Did it shorten the life? Did it introduce a new pain and suffering? Did it require wound care, surgeries, or long-term antibiotics? Did it require a move, a private sitter, a different facility, or hospice earlier than expected? The expert in economics may provide future care costs. Medical experts may testify about the course of pressure wounds or fracture outcomes. Families can testify about what changed day to day and really paint the picture in that way. And it really is kind of a storytelling, and it matters as much as the spreadsheets do. A jury can understand before the neglect, mom could walk with help to the dining room and recognized her daughter. After the neglect, she was bedbound in pain and afraid. That is a damages story. Let me give you a brief story example that may strike home with some of you. A man, Mr. Patel, places his wife in a nursing facility after a stroke. She can't walk alone. She has swallowing issues. She is alert. She smiles. She squeezes his hand. He visits every evening. Then his work schedule changes for 2 weeks, and he can only visit on weekends. On a Saturday, he finds his wife with a foul-smelling wound on her sacrum. She is lethargic. She is feverish. The facility says, "Oh, we noticed that recently." At the hospital, she is diagnosed with sepsis. She never returns to her baseline, and within a month, she is on hospice and she dies. When Mr. Patel later hears the word stage 4 pressure injury, he feels something break inside. Not just grief, but betrayal, because his wife didn't die of old age. She died of being left unmoved, unattended, and untreated. That kind of case is not about money as a prize. It's about money as accountability. It's about forcing the system to pay for the harm it caused, and sometimes forcing change on the facility. Now, damages also include something less obvious, the cost of carrying this. Families lose sleep. They lose trust. They lose the sense that the world is safe for the people that they love. That is not a line item on a bill, but it is real. Now that we've covered damages, how we quantify harm, and why these cases can be high value, in this chapter we'll talk about common defense tactics in vulnerable adult abuse and neglect cases, and how to counter them with facts, strategy, and a clear moral narrative. We've covered how these injuries happen, what they look like, and how to report and preserve the evidence, and how the damages are built. Now, in this chapter, we're going to have to talk about the other side, because in civil cases, the defense rarely says, "You're right, we failed. Here's fair compensation." They have a playbook, and if you've handled these cases such as I have, you already know the playbook is designed to confuse, fatigue, and devalue your case. So let's expose it as best as we can. Common defense strategy number 1 we'll talk about. It was unavoidable. This is the defense's favorite word in facility cases, unavoidable. They'll say pressure injuries can happen, falls can happen, old people get infections, dementia patients wander. And yes, those statements can be partially true, But the defense hopes you'll stop thinking there. The counter is simple. Risk is not an excuse. Risk is a duty. If the risk was known, the facility was obligated to plan for it, staff for it, and execute care to reduce it. The question is not, could it happen? The question is, what did you do to prevent it? And did you actually do that? I'm going to give you a pressure injury defense example. So they'll say, she was at a high risk. Your response is, exactly. That's why turning schedules, skin checks, and moisture management were mandatory. Show me the turning logs. Show me the skin assessments. Show me the escalation. So they'll have falls defense, and here's an example. They'll say, he was a fall risk. Your response is, exactly. That's why toileting assistance, call light response, and transfer protocols were there and required. Show me the staffing and the response times. Show me whether the care plan was followed. You'll get a common defense strategy number 2, which is, it was pre-existing. It was decline. This defense is emotional and cynical. They'll take the resident's vulnerability and use it as a shield. They were old. They had dementia. They were sick. They were going to die anyway. This is where you reframe. A fragile person is not worth less. A fragile person needs more protection. And legally, the concept is often acceleration and aggravation. Did the negligence accelerate decline? Did it turn manageable fragility into catastrophe? A resident can have dementia and still not deserve a broken hip from an unattended transfer. A resident can have diabetes and still not deserve stage 4 wound from being left in one position for hours. A resident can have heart disease and still not deserve sepsis from untreated infection. As an attorney, I'll counter this with timeline, medicine, baseline function, baseline weight, baseline mobility, baseline cognition, then the injury event, then the steep drop-off. Juries can understand this cliff. They understand before and after. So a common defense strategy, a third one that we'll discuss, is the resident refused care. You will hear this constantly. She refused to eat. He refused to let us bathe him. She refused repositioning. He refused meds. She was combative. Sometimes residents do refuse care, but refusal is not a magic wand. In facilities, refusal should trigger a higher duty. They need to assess, document, figure out alternative approaches, behavioral strategies, family notification, provider involvement, and care plan revision. If a resident with dementia refuses because they are fearful or confused, then staff must adapt. You don't respond to fear with neglect. As an attorney, strategies here include looking for whether refusal is documented consistently or only after harm. We look for whether staff tried alternatives or simply charted refused and moved on. We look for whether family was notified and look for whether a physician was consulted. We also look for whether there was any care plan changes after repeated refusals, which is important. A chart that says refused over and over without a plan is not a defense. It's an admission of system failure. I'll now talk about common defense strategy number 4. They'll say we documented everything. Documentation is not care. Charting is not turning. A signed flow sheet is not feeding assistance. Defense will often try to use a chart like a shield. See, we did it. Your counter is, well, show me the credibility. In electronic records, you look for identical copy-paste entries and possible timing, gaps where care supposedly happened but no one was staffed to do it, audit trails showing late entries after an incident. You'll also compare the facility chart, the hospital chart, EMS notes, the family photos, and witness testimony. When the narratives conflict, the defense loses the documentation equals truth advantage. So we'll talk about another defense strategy, which is number 5, understaffing isn't negligence, it's reality. This is the labor shortage defense. It's the we did our best defense. Let me be blunt. A vulnerable adult is not supposed to pay the price for business decisions. If the facility accepted the resident, collected payment, and promised care, then they had a duty to staff appropriately. If it chose not to do so, that is not a tragedy. That is negligence, often considered corporate negligence. As an attorney, this is where staffing records become our gold. Assignments, call-outs, agency usage, hours per resident day, and deposition testimony from frontline staff who quietly say the truth. We didn't have the time. We were always short. We didn't have what we needed. Those statements are not excuses, they're admissions of foreseeability. As an attorney, they're very usable in your case. Now we'll talk about Common Defense Strategy 6, arbitration. You signed away the courthouse. Many facilities push arbitration agreements during admission. Families are exhausted, scared, and signing stacks of paper. Sometimes the resident lacks capacity. Sometimes the signer doesn't have authority. Sometimes the agreement is buried or misrepresented. I'm not going to give you state-specific legal advice here because that enforceability depends on facts and the law of your state. But conceptually, attorneys like myself often need to evaluate whether the resident actually had the capacity to sign, and did the signer have the legal authority or power of attorney guardianship? Was the agreement a voluntary signature or pressured? We also ask, is it procedurally unfair or substantively unfair? Does it cover intentional torts like assault? Are there carve-outs that matter? Was it properly executed? For families, don't assume that signing something means the end of the road. Get it reviewed and don't sign new papers after an incident without understanding them. We'll now talk about Common Defense Strategy number 7. It was someone else's fault. Facilities sometimes blame the hospital. They came in like that. The family, you didn't visit enough. Another resident, we can't control other residents, or even a victim. They're just clumsy. The counter here is responsibility. A facility is responsible for the safety of its residents within the scope of the foreseeable risk. If a wound was present on admission, then the question is, what did the facility do next? Did it assess, treat, monitor, and escalate? If the resident-on-resident violence occurred, the question is, was the risk known? Were the prior incidents documented? Was the supervision adjusted? Were residents separated or protected? If the family didn't visit daily, then the question is, why does your business model depend on unpaid family labor to prevent neglect? Common Defense Strategy number 8. The injuries didn't prove abuse. This one's subtle. They'll say bruises happen, skin tears happen, infection happens. They'll call injuries nonspecific. Sometimes an injury is nonspecific, but patterns are specific. Multiple bruises in various healing stages, repeated falls, weight loss plus dehydration, pressure injury plus incontinence neglect, sedation plus falls, infection plus delayed escalation. Those are not random. They are a system talking. This is when your narrative matters. Instead of arguing each symptom is in isolation, you show the chain of events. Common Defense Strategy number 9. This case isn't worth much. The defense will try to devalue the human being. They will try to talk about the age, illness, and life expectancy of the person. They will treat the resident like a number. Your counter is dignity and pain. And as an attorney, the anchor is in the evidence. Was there wound photos, hospital records, pain notes, family testimony, and expert explanation of the suffering? A stage 4 pressure injury is not minor. Sepsis is not minor. Aspiration pneumonia is not minor. Sexual assault, not minor. And juries often respond strongly to moral clarity of these cases when presented with respect. Now, one more strategy point that is important: credibility. The defense often attacks credibility because it's easier than defending bad care. They may say the family is exaggerating. They may suggest the family is motivated by money. They may nitpick small inconsistencies, which is very common. So as the plaintiff's side, you do 3 things. First, you tell the truth plainly. even the inconvenient parts. If the resident had dementia, you say it. If the resident had prior fall history, you say it. You don't hide reality, you frame it. And your attorney, like myself, can help you with this framing. Second, you focus on the strongest, most provable failures. Not every complaint needs to be in the case. Pick the failures that are documented, repeated, and clearly tied to the harm. Third, you humanize without melodrama. You don't need to scream. Let the facts breathe for themselves. A photo of a pressure injury doesn't need a speech. A timeline of weight loss doesn't need theatrics. A hospital record documenting dehydration speaks in cold, clean voice that juries will trust. To conclude this chapter, the defense playbook is designed to make the harm seem normal, inevitable, and unprovable. Our job is to show that it was foreseeable, preventable, and documented. And when you do that, the playbook burns. Now, having walked you through cases, settings, injuries, reporting, proof, damages, and defense tactics, it's time for our final chapter, bringing it back to the human journey. In this final chapter, we'll talk about the family's journey after suspected abuse or neglect, the emotional reality, the practical steps, and how the legal process weaves into the fight to protect someone that you love. Now, we've covered a lot of ground: the mechanisms of harm, the settings, the injuries, the evidence, the legal theories, the damages, and the defense tactics. Now we can step back, talk about what it looks like in real life. Because the truth is, these cases don't just happen in charts, they happen in families. And the family's journey often follows a pattern. Even though every story is unique, there's common paths. So phase 1, the feeling you can't shake. Most families don't discover facility neglect in a dramatic moment. They discover it slowly. It starts with a subtle change. Mom is more withdrawn. Dad seems more confused. Your loved one's clothes are dirty. Their room smells like urine when it shouldn't. They seem sedated. They flinched when a certain staff member enters. They have bruises without explanations and don't make sense. They lose weight and nobody seems alarmed. And this is where families get trapped emotionally, because you want to trust. You want to believe professionals are doing their job. You want to believe you're not that family, the one who complains. So you second guess yourself. Let me say this plainly. Second guessing is normal, but don't let it become paralysis. If your instincts are saying something is wrong, treat that instinct like a smoke alarm. It doesn't prove there's a fire, it tells you to look. Phase 2, the first confrontation and the first deflection. Now I want to talk about the first confrontation and the first deflection. Families often start by asking questions. That's very reasonable. They ask, why is there a bruise? Why has she lost weight? Why is he sleeping all day? Why did we not get a call about this fall? Why does this wound look this bad? And often the response is deflection. Oh, it's normal. It happens. She's difficult. He refuses care. We're short-staffed. We followed the procedure. Sometimes you'll get friendliness. Sometimes you'll get irritation. Sometimes you'll get that subtle message. You're being inconvenient to us. That message is a tell. Good care settings welcome family involvement because it improves outcomes. Bad care settings see family involvement as exposure. Phase 3, the pivot: safety, documentation, outside help. At some point, families often reach a pivot moment. A fall leads to the ER. A wound is discovered. A resident says something alarming, or a family sees something they can't unsee. This is where action becomes necessary. The first question is always, is the person safe right now? Sometimes the safest move is medical evaluation. Sometimes it's a transfer to a different facility. Sometimes it's bringing the person home temporarily. Sometimes it's hiring a private sitter as a bridge. There's no perfect answer for every family because every family has different resources and limitations. But there is a guiding principle. Do not leave a vulnerable adult in a setting you no longer trust if you have a reasonable way to remove them. At the same time, you document. You take photos, you keep a log, you preserve messages, you request records, and you create outside records. Medical providers, APS, Ombudsman, licensing agencies, law enforcement, when appropriate. Now we're at phase 4, the emotional storm, the guilt, anger, and grief. This part doesn't get talked about enough, and it matters. Families often carry crushing guilt. How did I not know? Did I put them here? Did I fail them? Let me say this clearly. You did not cause the facility's neglect. You did not cause a corporation to understaff. You were not the cause of the caregiver's abuse. You made a decision based on the information you had, often under stress, often after a hospitalization, often while juggling work, life, and children and your own health. That's what families do. Neglect thrives on the fact that families are human and can't be present 24/7. Anger is also common, and it's justified, because this is not an oops, this is someone's taking money to provide safety and failing to provide safety. Grief is also common. Sometimes grief for the person's decline, sometimes grief for the loss of trust, sometimes grief for the feeling that the world is not as safe as you believed. As an attorney, this is where I can inform a family. The clients are not just plaintiffs. They are people who feel like they were failed by someone. My job is to hold the facts with compassion and give them a path forward. Phase 5, the decision to pursue a legal case. Not every bad facility experience becomes a lawsuit, but some should. A legal case is often necessary for 3 reasons. 1, to pay for the increased care needs and negligence created. 2, to hold accountable wrongdoers, accountable in a way that gets their attention. And 3, to create a record that can protect others. Families sometimes hesitate because they don't want conflict. It's understandable. They don't want the stress. They don't want to be sue happy. But here's the counter truth. Civil accountability is one of the only levers families have in a system that often is built to protect institutions first. A facility can ignore a complaint. It cannot ignore discovery. It cannot ignore subpoenas. It cannot ignore expert testimony. And it cannot ignore a jury. Phase 6, what the legal process actually looks like. Let's try to demystify it. Step 1, the consultation and intake. So as an attorney, I will listen first, not just to the injury, but to the timeline, the setting, the resident's baseline, and what changed. I will ask, what was the resident like before? What were their known risks? What was the care plan that they were giving? When did you notice the changes? What did the hospital tell you? What do you have for photos or logs, if any? I will also ask about powers of attorney, guardianship authority, which is the authority to act, and arbitration documents. For families, this may feel like a lot, but it matters because these cases are detail-driven. The second step, the records and early investigation. Facility cases live in the records, and as an attorney, I will often request the entire facility chart, incident reports, the care plans, MAR/TAR, wound documentation, weights, staffing records, and any available video. I may also request hospital records, EMS records, urgent care records, and prior baseline records. I do not delay getting out a preservation letter, which tells the facility to keep everything that they have in their possession. I'll often consider early on whether the resident testimony needs to be preserved. Video depositions, affidavits, or recorded statements, especially if the resident is medically fragile. Step 3, experts and theory building. A strong case usually involves early experts review. Why? Because the defense will eventually claim no breach, no causation, no damages. Experts help build a clean, defensible narrative early. This is what the facility knew. This is what the standard of care required. This is what they did instead, and this is how it caused harm. Step 4, filing and litigation. Once a case is filed, the defense responds. There may be motions, arbitration issues may be raised, corporate entities may try to hide behind layers. Then the discovery begins, and this is where the truth often emerges. Depositions can be hard for families. They can feel invasive. They can feel like the defense is putting the victim on trial. As a family member, you may be asked about why you chose the facility, how often you visited, what you noticed, whether you complained, and what your loved one's baseline was. Defense may try to imply that you didn't care enough and you were exaggerating, or that this is all just grief turning into blame. That's why preparation matters. Not coaching, just preparation. It's about being calm, factual, and clear. It's about saying, this is what I saw, this is what I documented, and this is what changed. As an attorney, we prepare family witnesses to avoid speculation, to stick to direct observations, and anchor their timeline. Staff depositions. These can be the heart of the case. Frontline staff often reveal the truth, even unintentionally. Questions that matter. How many residents were you responsible for? How often did call lights go unanswered? Were turning schedules realistic? What happened when someone refused care? How were aggressive residents handled? Were you trained? Were you supervised? Sometimes staff will defend the facility. Sometimes they will quietly admit systematic failure. We were always short. We did what we could with what we had. There was no time. Those statements are evidence. They show the foreseeability. EHR and audit trail discovery. In modern cases, EHR audit trails can show late entries, backcharting, copy-paste patterns, and changes after an incident. This isn't about catching people in a gotcha moment. It's about separating real care from paperwork after the fact. Step 5, the resolution process, settlement, mediation, or trial. Most cases will resolve before trial, often through negotiation or mediations. But facilities and insurers often test families' endurance. They will delay, they will minimize, they'll make it a low offer initially. A strong case resolves better because it's prepared for trial. Settlement should not feel like selling the loved one's story. It should feel like securing resources and accountability. Now, trial. When it happens, it's emotionally intense, but in the right case, it can be clarifying. A jury's verdict can speak for a resident who could not speak for themselves. Now let's talk about something that is unique in vulnerable adult cases. The resident may not be able to tell the story, so the family becomes the storyteller, and the body becomes the evidence, and the records become the timeline, and the experts translate it all. That's why these cases are so important and why they require a particular kind of care in the legal approach. So we'll talk about a composite story, the Carter family. Let's bring this together with a story, again, a hypothetical, but built from patterns families often describe. So the Carter family, their mother, Elaine, is 79 and living with moderate dementia. She is forgetful, but she still knows her daughters. She laughs at old photos. She loves church, music. She needs help with bathing and medication, but she's still Elaine. After a hospitalization for pneumonia, the hospital recommends rehab. The family's overwhelmed. They choose a facility that looks clean, has friendly staff, and promises strong memory care support. For the first week, things seem okay. Then the daughters notice changes. Elaine's hair is matted. Her nails are dirty. She smells like urine. She seems unusually sleepy. They ask the staff, and they're told she's just adjusting. She's confused, and she refuses showers. One daughter visits on a weekday morning and sees something else. Call lights are ringing down the hall, unanswered. A single CNA is moving fast, eyes tired, doing triage. Elaine is sitting in a chair, slumped, unattended. The daughter's stomach drops. She doesn't know exactly what's wrong yet, but she knows the vibe. She knows the math doesn't work. A week later, Elaine falls in the bathroom. The facility calls late, after hours. They say Elaine tried to go on her own. She is sent to the ER, diagnosed with a hip fracture. Surgery happens. Elaine returns weaker, more confused. At this point, the family is in full crisis mode. They request a care conference. They ask for a fall prevention plan. They ask about toileting assistance. They ask about medication changes. They get vague answers. They get phrases instead of facts. Then 2 weeks after the fall, they find a wound on Elaine's sacrum. It's not a small sore, it's deep. It smells. Elaine cries when they gently reposition her. The facility says, "We're treating it." But the family has learned not to trust the words without proof. They photograph the wound. They take Elaine to the hospital. The hospital documents an advanced pressure injury with infection. She is admitted for IV antibiotics. At the hospital, a nurse asks the daughter a question that hits like a hammer. How long has this been there? They don't know, and the not knowing breaks their hearts. The daughters file an APS report. They file a complaint with the licensing agency. They request the records. They ask the facility for wound logs and turning documentation. Then something changes. The facility becomes defensive. They start saying Elaine was non-compliant. They start saying she refused care. They imply the family is overreacting. Elaine's hospice course is complicated. She becomes delirious. She aspirates. She develops pneumonia. She declines. Within months, she is placed on hospice and she passes away. The daughters are left with grief and a question. Was this inevitable, or did neglect accelerate and worsen everything? They meet with an attorney. The attorney requests records, sees Elaine's care plan, lists her as high risk for skin breakdown. Turning was ordered, skin checks were required, weights were supposed to be tracked. But the turning logs are sporadic. Documentation is copy-pasted. The wound appears in charting days after it must have been present. There is no timely escalation. Staffing records show chronic shortages. The case is filed. Defense argues she was old, she had dementia, she refused care. Pressure injuries can happen, but the plaintiffs show a timeline, photos, hospital documentation, and expert testimony explaining preventability and suffering. In mediation, the defense offers low offer. The family refuses this. They are not chasing a jackpot, they are demanding respect for what happened. As the case moves forward, more comes out. Staff felt pressured to chart tasks completed even when they were not. The management knew staffing was inadequate. Eventually, the case resolves with significant compensation. The daughters use the funds to pay for the medical bills. They cover the cost of the family incurred. They support their father, who depended on Elaine's caregiving and presence in ways money can't measure. But the daughters also do something else. They speak to regulators, they share documentation, they push for change, they keep Elaine's story from disappearing. On the day the case resolves, one daughter says something that captures why the case matters. We couldn't save her from dementia, but she didn't have to suffer like that. That sentence is the heart of vulnerable adult cases. You cannot stop aging, you cannot stop disease, but you can stop neglect. You can stop cruelty. You can stop the business model that treats care as a cost to be cut. Now that we've gone over a story of a vulnerable adult, I'd like to talk about retaliation fear. This is the question of, will they treat them worse if we complain? This is a fear that's real, and families worry that if they speak up, the staff will take it out on them and the resident. Most caregivers are not cruel, but in a dysfunctional facility, retaliation, subtle or overt, can happen. So how do you protect your loved ones while you advocate? Increase your presence if you can. Bring another family member or friend to the visits. You can put concerns in writing, calmly and factually. Ask for care conferences with the management present, and use outside reporting channels. You can consider a private supervision as a short-term bridge if necessary, and if you feel the environment is unsafe, plan a transfer. As an attorney, this is another reason that we early get the documentation of these matters. It reduces the facility's ability to isolate the family and control the narrative. I'm now going to talk about attorneys' strategy in the first 30 days of a strong case. As an attorney, I want to build these cases right away, and early window matters. Here's a practical framework for how I approach a case, and it's not general, but it's specific and highly usable. First, I preserve everything immediately. Send a preservation letter that targets not just the chart, but the EHR, audit trails, wound photos, surveillance video, staffing schedules, assignments, incident reporting systems, and make them commit to retention. 2, I get the admissions packet and every signed document. The admissions packet often includes the arbitration agreement, any responsible party, language, and sometimes buried disclaimers that defense will later try to work with. 3, I'll identify all corporate players early: the owner of the entity, the management entity, license entity, real estate entity, staffing agency, medical care provider contracts. I don't let defense box us into suing the facility as a single name when the decision makers are elsewhere. Number 4, I'll get outside records first: hospital records, EMS records, 911 call records where available. These often anchor our case timeline and cut through the facility's spin. 5, I build medical timelines in a single document that includes a baseline, admission, known risks, care plan requirements, and documented failures. Also, the injury onset, escalation demands, any hospital transfer or outcomes. A clean timeline is a map for a demand letter and a backbone to a trial. This roadmap is essential in the case. 6, I'll get early expert input. Even a preliminary nursing wound geriatric review can help choose the right legal theory: negligence, medical malpractice, corporate negligence, statutory vulnerable adult claims, intentional torts, or a combination of them. 7, I'll preserve resident testimony when appropriate. If the resident has a capacity and can describe what happened, even partially, I'll consider early testimony preservation. If the resident is fragile, I'll consider video deposition sooner rather than later. Time doesn't pause for litigation. Family-facing strategy: how to advocate without burning out. For families, here's the truth. You don't have to become a professional investigator to protect your loved one, but you do need a plan. Ask for the current medication list in writing. Ask for the current care plan or service plan in writing. Ask for recent weights and nutrition notes. Ask for skin assessments and wound documentation if there are wounds. Ask calmly who is responsible on the next shift and how can you reach them. Put key concerns in short written message so that there is a record. If you're not getting answers, go up the chain. Director of nursing, administrator, corporate line. Use outside reporting channels when the facility is not responsive. You're not being difficult, you're being protective. And if anyone makes you feel guilty for asking basic questions, that tells you something about the culture that you're dealing with. A brief word on prevention: trust, then verify. A lot of families ask, after the dust settles, how do we prevent this from happening again? There's no perfect shield, but there are practices that can reduce risk. Visit at unpredictable times when you can. Patterns reveal themselves outside the scheduled show hours. Watch the basics: cleanliness, hydration, responsiveness, and mood. If those basics are failing, bigger failures usually exist too. Ask about staffing directly, not in a hostile way. Just directly attend care conferences and insist on written updates when condition changes. When a new medication appears, ask why. Ask what side effects to watch for. Ask who is monitoring. If your loved one has known risks, such as falls, skin breakdown, or swallowing, Ask what specific interventions are being done and how often. If you have concerns, put them in writing. Calm, factual writing creates a record and forces clarity. And here's a hard but useful truth. If a facility makes you feel like your presence is the problem, the facility is the problem. The good places want your involvement. They don't fear questions. They don't punish transparency. The bad places treat your family involvement like an enemy because it interferes with shortcuts. So you don't need to be aggressive. You just need to be present, consistent, and unwilling to accept vague answers when the stakes are human life. Now we're going to talk about what you can do now, the practical steps. Let's get close with practical steps you can take right now if you suspect a vulnerable adult is being harmed. Number 1, trust your instincts and look for patterns. One odd thing can be random. A pattern is a warning. 2, increase visits if you can and vary the timing. Different shifts look different. Weekends look different. Night shifts look different. Number 3, document. Photos, dates, names, what was said, what was promised. Keep it simple, but keep it consistent. 4, get independent medical evaluation when you see injury or sudden change. Hospitals create records that matter. So do urgent care providers. So do your primary care physicians. 5, report when appropriate. APS, the licensing agencies, law enforcement when there's a crime or immediate danger. 6, preserve evidence and ask about video retention. Request records. Do not assume the facility will keep what you need. 7, if the situation is serious, talk to an attorney like myself who understands these cases. Not every attorney does. These cases require medical literacy, record literacy, and the willingness to push through the defense playbook. 8, if you can't move them immediately, build a temporary safe net. That can make asking for increased supervision in writing. It can mean hiring a private sitter for a short period. It can mean requesting a skin check and a wound consult now, not a week from now. It can mean asking for swallow precautions and meal supervision to be clearly written and followed. Sometimes the short-term goal is simply stabilize and stop the bleeding while you plan the next step. 9, don't carry this alone. Talk to other family members. Talk to your loved one's doctor. Talk to your advocate. And if you're overwhelmed, that's not weakness. It's evidence that you're human. These situations can be traumatic, and getting support helps you make clear decisions instead of fear-based ones. As an attorney, I treat the family like people, not case intake. I explain the process. I control the timeline, get the records early, preserve testimony when necessary, and build the narrative. And never let the defense devalue the resident's humanity. I wanted to add just some final thoughts to the video series as we wrap it up. I want to name something that gets lost in legal language. These cases are about dignity. They're about what we owe vulnerable adults when they can't fight for themselves. They're about the quiet promise a facility makes when it takes someone in. We will keep them safe. We will care for them. We will treat them as a person. When that promise is broken, families often feel alone. But you are not alone. There is a path forward through medical care, through reporting, through documentation, through legal accountability, and through the simple act of saying, no, this is not acceptable. And if you're wondering whether any of this makes a difference, I want you to hear this. Facilities pay attention to the patterns. Insurance and insurers pay attention to risk. Corporate decision makers pay attention to consequences. When families speak up, when reports are made, and when cases are pursued with discipline and dignity, the system feels pressure to change, sometimes in staffing, sometimes in training, sometimes in policies, and sometimes in who gets hired and who gets fired. It doesn't fix what happened, but it can keep someone else from suffering the same way. Thank you for listening through this journey. I hope the information has been clear and useful, and above all, a reminder that behind every chart, every incident report, and every case file is a human being who deserved better. My name is John Kelly, and I'm an attorney who handles vulnerable adult cases. I hope you've gathered some information that was helpful through this series. If you have additional questions about a vulnerable adult case, I'm happy to help you. I help people throughout the nation. I work at Kelly Law Team, and our number is 602-283-4122.